Again, here we are from Tierspital University of Zurich, and we are still talking about critical care. Fluid therapy is the topic of the next few lectures, except for some intervals about how to triage a patient and then maybe how to fill out the triage sheet on arrival. And fluid therapy definitely is a very important, relevant topic in emergency and critical care medicine. So I'd like to discuss some important principle related to that. And as we discussed on the previous lecture, we started with fluid resuscitation. And but I don't think at that time I covered one of my most important ideals and tenets of approach to medicine and science. Good idea come from curiosity. Curiosity is intrinsically irreverent, and good idea naturally have to be irreverent. So what I invite you to do is to dare to be irreverent, no matter of what message you hear, no matter who you hear it from, no matter how authoritative is the institution, the article, the publication, or the person that presents them. Be irreverent, doubt of anything you hear, look for yourself, investigate farther, because there's nothing worse than sit on a message without having really put your hands onto where it came from, how it was detected, and how it was proven, and whether that is universally true or not. Daring to doubt is always considered irreverent, especially by whoever or whomever believed to be the keeper of truth. There's no such a thing as the keeper of a truth. There's no such a thing as a universal truth, especially when we're talking about science and medicine. Those truth is searched, truth is updated, truth is applied and then tested in science and medicine. And medicine is a science until proven otherwise. So please, dare be irreverent doubt of anything I say, anything that anyone says. Related to fluids, the basic compartments that we like to think about are the ones that compartmentalize, although with a constant entropy between such compartments, the distribution of water within the body. The total body water has somewhere an approximation of roughly 0.6 liter per kilo, varies between species, varies between gender, varies between ages. But in an adult scenario, about 0.6 liter per kilo in a dog seems to be fairly appropriate, with 60% roughly of such volume being distributed within the cell, and that would be called intracellular fluid volume, and 40% of the total body water being instead extracellular. This is the first two compartments where there's a constant entropy and movement of water within and inside and outside the cells, where the two compartments are not isolated from one another. The intravascular fluid volume is just a fraction of the extracellular fluid. About 20% of the extracellular fluid is represented by the intravascular fluid volume. Even more so in this circumstance, where between the intracellular and the extracellular fluid volume, there's a barrier, which is the cell wall, that tends to maintain a very tight regulation of inflow and outflow of electrolyte, where energy dependent channels maintain such balance in tight control, and so forth the movement of water is also tightly regulated. Such regulation does not exist between the compartments of extracellular fluid and the intravascular fluid volume. The intravascular fluid volume, as I said, is just a representation of a compartment of the extracellular fluid. So there, electrolytes and water move across the intravascular barrier, namely the endothelium and the vessel wall, very, very freely. The total blood volume, which is obviously the amount of blood that is circulating as well as not circulating in a animal, or for a matter even a hairless monkey, aka human being, where we're going to have a division between stress volume and unstressed blood volume, where the stress volume is the one that directly support perfusion and circulation, which is the active drive of the active circulating volume. And then we have the unstressed volume, which is that blood pool that is there ready to go, mainly restricted to the splanchnic circulation, but as well sitting in the dermis, for example, and the spleen, which is a reservoir in many species. Certainly in a dog is a major reservoir of blood volume that is ready to be used by a kick of splenic contraction as needed, as a sort of a mini fluid bolus that the patient can give himself in a condition of need. The total blood volume has been measured in many species, measured by exsanguination in the early years of 1900, and or at least of that was the time that we have reports, but also then assess once again with nuclear marked studies where chromium and other agents were used to kind of detect the total cell volume as well as plasma volume of dogs, cats, pigs, rabbits, and so on. So this is just some numbers to keep on hand. Once again, for the matter of therapeutic use, are not as relevant as one may think, but at least give us some reference. Here, just on a pictorial aspect, we're going to have our intracellular compartment, extracellular fluid volume, and the intravascular fluid volume, which is just a compartment of the extracellular fluid. While, as we covered already for in regard of resuscitation on a previous lecture, the ultimate goal of resuscitation is to restore circulation and perfusion by restoring the intravascular volume, and that wants to be done rapidly, either to assess if that patient is a volume responder or not in a matter of a fluid challenge, or therapeutically if there's a confirmation or sufficient clinical signs to support the diagnosis of hypovolemia, or reduction of perfusion and circulation due to a reduction in intravascular fluid volume. Once again, here we don't need to cover any further. We already covered these aspects on the previous lecture, and we already covered why actually colloids do not provide at all a better fluid expansion compared to crystalloids. These are some articles on the topic, but actually science now tell us the opposite. The crystalloid do just as good of a job as colloid, with maybe less side effects than those, and actually it lasts just as long, the fluid expansion generated by a crystalloid, than a colloid. So dogmas are there to be debunked rather than be respected, adored, or cherished. So please keep debunking dogmas. Please keep doing it. And also, once again, using albumin versus saline or balanced fluid better, said for fluid resuscitation in intensive care unit. Once again, no difference in major human studies that included a variety of patient populations, all hospitalized in intensive care unit. I don't have a reason to believe that in veterinary medicine we are ever going to be able to have numbers that are going to be able to either prove or misprove definitely the value or the advantage of albumin or other colloids over or against crystalloids, balanced crystalloids, just because, as I said, if we keep sticking with our 6 dogs for statistical power to then be able to publish an article, that to me is just only sad rather than useful. And once again, regarding to head starch, it's true there's no definitive finding that in dogs and cats it increases the risk of acute kidney injury, and whereas in humans those findings were sufficient and strong enough to actually have a black box in the United States and all over the world for the use in human patients, septic human patients, in septic patients using these drugs. And I remind you, these are drugs, synthetic colloids, namely head starch, no matter what substitution value or molecular size you're using, are contraindicated on a black box, so you should not use it. In veterinary patient, these findings were never proven. However, in animals, namely rats, as you see in these 2 graphs, and this is a study that showed that, balanced hydroxy head starch, namely was actually the small molecule 130.4 substitution, impair kidney function in vivo, and such impairment, meaning drop in GFR and cytotoxicity that was identified at incremental concentration of head starch, was not associated with an inflammatory tubular response or formal nephritis. It appeared to be a direct effect of a head starch. And the conclusion from that finding is sepsis. In sepsis, head starch should be avoided due to higher risk of acute kidney injury. Well, this is a publication from 2015, and certainly is the most well presented, where both histopathology as well as GFR were measured in those animals. So we have finding in animals, just as not as clinically relevant because we don't treat rats as often for sepsis as dogs, but still it's not true that in animals was never shown that head starch is not nephrotoxic. It is, and this is the end of the story as far as we know up to this moment. I'm sure that there are going to be attempts to prove that out of 6 dogs or cats that were treated with head starch, no impairment of renal function measured with changes in creatinine was seen. Those would be meaningless as far as I'm concerned to change the reality of what we have now knowledge of based on these studies that I just presented. So the topic, actually primary topic of today's presentation, is replacement therapy. And replacement fluid therapy is basically the second stage of fluid therapy when we are evaluating a patient in the emergency department, and then even more importantly in a critical care unit. We resuscitate certainly in the emergency department, and sometimes unfortunately ICU patients require fluid resuscitation as well. As I said, either for a fluid challenge to whether decide if fluids is anything that is going to be beneficial for the enhancement or improvement or optimization of the hemodynamics of that patient. Or therapeutically, if we decide that certainly we have sufficient signs to recognize hypovolemia as the primary reason of hemodynamic instability of these patients. Replacement therapy, instead, has the aim to restore losses that have occurred primarily in the extracellular compartment over a period of time. Replacement therapy does not have the aim to improve circulation. Replacement therapy has the goal to restore fluid losses and electrolyte losses then the patient has had over a period of time that varies from a day to a week to a month, depending on the chronicity of the losses that patient has had, without being able to replacing it with appropriate intake. So for replacement sort of tenants, the ones that we want to consider is normally isotonic fluid solutions are the ones that are used, where balanced are the ones that are kind of commercially available, where Ringer lactate, Ringer acetate, Normosol, Plasmolite, Vedivax, to name some of those that are largely available on the market. The ultimate goal of fluid replacement is restore the extracellular fluid volume. And the therapeutic approach to fluid replacement therapy is largely based on the estimation, clinical estimation of the deficit in percentage. And that, I remind you, is a clinical estimate. And we're going to talk about such clinical estimate in a second. Once you have estimated the percentage deficit that such a patient has, you can then know how many mLs that patient likely needs or potentially needs based on your estimate. And such deficit multiplied by body weight then will allow you to say how many mLs of fluids you want this patient to receive. One consideration also is, yes, sadly in veterinary patients we have obesity as a disease as much as unfortunately in people, if not worse. And so please at least have a consideration of having the use of lean body weight rather than the total weight of the animal. Don't try to estimate the degree of dehydration or fluid deficit of a cat that should be 5 kilos, but unfortunately is 12 because of how obese it is, and then calculate that total volume of water to be replaced in that animal over a short period of time, 12, 24, 48 hours, because what is going to happen is a guaranteed cardiovascular overload of fluids that certainly his cardiovascular system is not adapted to feed and to be withstanding the preload of a 12 kilo patient, 12 kilo animal. So please at least use lean body weight. And then the rate of replacement is usually based on the pre-existing condition and the severity of the deficit. Like Addisonian crisis patients, those are classical patients that following an initial resuscitation, normally they also require a pretty aggressive replacement. DKA patients, diabetic ketoacidosis patients, those are another population of patients where certainly you are entitled to be fairly aggressive on your fluid replacement. So 12 hours certainly seem to be appropriate to achieve a full replacement of the losses that were estimated. Very severe deficit, as I said, the extracellular compartment is an extension of the intravascular volume. So when you have a patient with severe deficit in extracellular fluid volume, automatically they will have intrinsically a hypovolemia associated with it. In those cases, resuscitation is performed first and replacement is just the second stage of the optimization of care for these patients. So as I said, I wanted to make a little parenthesis about our estimation of fluid balance in our patients, and with the idea that unfortunately, and the knowledge that unfortunately what we do is making up a number based on some findings on the clinical presentation on animal to decide how many mLs of fluids we want to give. As I always tell at any lecture that I give on a topic, every single patient that comes through the ER with a history of vomiting or having diarrhea, no matter if it was one single episode or 15, is estimated as dehydrated. Sometimes my new intern class comes in and a dog or a cat vomited once. They come saying, oh, he's 5% dehydrated, I think, because he has dry mucous membrane. Okay. So he comes to me and says, oh, he's a cat, so he's 5% dehydrated. Okay, so he's a 5 kilo cat, is 5% dehydrated, so I want to give him 250 mLs. Well, at least you can do math. That's good. And then they tell me, well, I think I can give him over 12 hours because he's cardiovascularly healthy and he doesn't have any risk of cardiac overload, so I think I can give him these mLs over the next 12 hours. Okay. And then the next question that I ask him is, let's say that you were that cat. And then they look at me like, what? Are you losing your mind? And no, I repeat the question and said, okay, let's say that cat, it's you. You had vomited once, and now you go to your doctor, who, based on the dryness of your mucous membrane, decides that you're 5% dehydrated. Please tell me how much fluid he's planning to give you. And so if your doctor just estimates your body weight as just as you estimated the one of your cat, maybe you even measure the one of your cat, unlikely your doctor is going to weigh you, then you are, let's say, 70 kilos. That's perfect. You're 70 kilos and your doctor decides that you're 5% dehydrated. You're 5% dehydrated, and so 70 kilogram times 5% would be 3.5 liters of fluids that he wants to give you over a 12-hour time period. You can drink, so it forces you to drink 3.5 liters of fluids because you have vomited once or twice that day. I know that automatically at this statement or this comparison had made many of you laugh, and some of you think on all the times that you instead have deemed the patient, not cat or dog, not only 5% dehydrated, but maybe 7, 8, 9, 10% dehydrated. Never mind that a degree of 10% dehydration is basically a lethal condition, and never mind that there's not such a thing as a patient being 10% dehydrated without being severely hypovolemic at the same time. But 5%, although it is basically the standard of care for any patient that comes through the ER, being a cat or a dog, because at least allows us to do something, no matter what the primary condition is, at least we can pull up that damn bag of fluids and give them some. Still, please at least have a consideration that that animal, if it vomited truly once or twice, or he had one episode of diarrhea, would be the equivalent that you deem him being 5% dehydrated of you having to receive 3.5 liters of fluid. I don't think any of you has ever been able to puke 3.5 liters in one single attempt or even twice, or certainly has never had one single episode of diarrhea producing 3.5 liters of it. Because if that's the case, you don't need to go to the ER. You need to call an exorcist. That's what I believe. I know, it's pretty funny. So never mind. That was a little parenthesis, but here's some paper to tell us how good we are at assessing hydration versus dehydration. Well, I picked some article in a human literature, because in the veterinary literature, unfortunately, despite the fact we seem to be very good at doing it, we don't publish about it, so nobody can look into it. So the evaluation of clinical signs in the diagnosis of dehydration in children with acute gastroenteritis: sunken eyes, decreased skin elasticity, weak radial pulse, and general appearance, which is, oh, by the way, those are exactly the most common reason why my interns tell me that they want to give 5%, 7% rehydration to the patients that comes in. The conclusion of this study is that none of the 10 finding studies, and those are just some of the ones that you see over there, is sufficiently accurate to be used to determine hydration status. And even in combination, the reliability as assessing hydration, and these patients then were obviously compared with weight gain when they were deemed hydrated, or when they went through the crisis of acute gastroenteritis, none of them proved to be able to predict the degree of dehydration. Not only that, the clinical assessment, what was shown, consistently overestimates the presence and the degree of dehydration. So what was shown in this paper from 1989, actually, again, Clinical Signs of Dehydration in Children, showed the relationship between estimated and true dehydration, with the percentage dehydrated and the number of patients respectively on a horizontal and a vertical axis. axis of this graph that you see over here, vertical axis here, number of children involved, and here percent of dehydration. Here we see that the estimate of patients that were deemed dehydrated, the solid bar is a true percentage of hydration, and hatch bar estimated percentage of dehydration. So this is the estimate that was given. You see that the 5 or 6%, the good news is that us, veterinarian, interns, residents, whoever is managing patients, is not worse than human doctors that do the same on kids. So at least that can make us feel a little better. We are not worse than other. Doesn't mean they were good, meaning if we are all in the same batch or in the same sad situation, doesn't make us better. It's still pretty scary. But what happens if we use clinical science to assess dehydration? Well, consistently we overestimate the degree of it. Not only, we are so bad at relying on clinical assessment that we can't even tell whether dehydration is present or not. Here, it's not only the degree, but even the presence. Meaning many patients could be overhydrated, and we deem them dehydrated because we rely so much on clinical signs that have been shown over and over to be ineffective, unreliable, deceptive at indicating the fluid status of the patient. Despite that, we keep doing it. So I give you this bottom line on fluid replacement. And these are 4 tenets that I like every single one of you at least to think about. As I said, not follow, but at least think about. What we know by evidence, clinical evidence and science, is that we suck at assessing the hydration status in our patients. The second thing we know is that often we overestimate the dehydration status and percentage, which means that often we overhydrate our patients. And another thing that now actually we know very well and has been shown very strongly and scaringly is that volume overload kills patients. So with those considerations in mind, maybe you can have a different approach on how much fluids and how often you want to rehydrate your patients because they have losses that maybe you weren't able to estimate properly. Here we have some formulations of replacement fluids, as I said, isotonic solution, where normally the sodium concentration is the driving force of the osmolarity for such solution, and it ranges anywhere between 130 and 145 depending on the solution. The chloride concentration is consistently lower than normal saline, where, as we know, sodium and chloride are in equal concentration, and there's nothing physiologic about the normal saline. There's nothing normal about it, and there's nothing physiologic about it. And so that chloride concentration that we spoke about in the resuscitation lecture being detrimental in outcome, detrimental in renal function, detrimental in enzyme function once acidosis from hyperchloremia ensure, is definitely better controlled in using replacement solution that are balanced isotonic solution rather than sodium chloride. Calcium is present or not depending on the type, and obviously all replacement solution has a certain content of potassium as well. So how do you estimate ongoing losses? On arrival, the cat or the dog, is nearly impossible that you have an idea of how much losses they have. Well, so at that time, yes, you have to dare, once again, you have to dare to decide if the losses that the animal has had were not properly replaced. So there's a true deficit of the total body water of these patients, especially extracellular compartment of it. So you decide a number empirically, and then you reassess your patient. However, as I said, if you still use clinical science to reassess it, you were deceptively driven to decide it was dehydrated on the first run, and then you're going to be deceptively driven to either again establish that the patient was dehydrated because of some mild xerostomia, or still decide that he's doing better just because you're biased by the fact that you already gave him a buttload of fluids. So once again, the reevaluation might not be very effective. So basically, at the beginning, you're gonna dare, just again, remember the 4 tenets that I just talked about. But the ongoing losses in a hospital, especially in the intensive care unit, are easy to assess. There's no patient that becomes skinny or fat over a 24-hour period. Otherwise, we will be bathing suit ready from July 14th to July 15th, and then we will be from skinny to fat over Christmas Eve. And we don't. So there's no patient that becomes skinny or fat over a day. So normally weight changes that occur over 6, 8, 12-hour period are only related to change in total body water. So measuring obviously where most of the water come from, urine output, could be a really good way to assess the losses potentially in excess from the intake. But once again, not all patients, even in intensive care unit, have a urinary catheter. And weighing pee pads or weighing, estimating losses in a cage is largely unreliable. So what can you do? Well, you can weigh your patient. You can weigh your patient on arrival and weigh your patient every 8, 12 hours, especially if you're worried about the losses that are ongoing and how much intake you want to deliver. So account for losses in diarrhea and vomiting, or panting for the matter. That would be an insensible loss that are hard to be accurate on. So weighing your patient might be the best tool that you have available. Obviously, if you are weighing a little nugget like the one that you see in the picture here, yes, you need a gram scale, because that dog is not going to lose a kilo. He weighs 800 grams. So if he loses all of a sudden 50 grams, or if he gains 50 grand, not grand, he might cost 50 grand to treat him properly. No, I'm kidding. But he might gain or lose 50 grams very easily. But that 50 gram is a drastic percentage of change, especially if it occurs over an 8 to 12 hour period, both in the direction of dehydration as well as in the direction of overhydration. So yes, you need to be accurate and reliable in your weighing of your patients, especially the smallest ones. And yes, patients are weighed even in the middle of the night, even if they get pretty upset. We see here another patient, this is a dialysis patient, is being weighed every 6 hours, especially if you have issues with polyuria or oliguria. Those patients can have massive losses or massive weight gains due to one side polyuria and dehydration, and the other respectively overhydration for too aggressive fluid administration. So yes, you weigh them and you keep doing it, because the changes that you want to have should be minimal unless you were attempting, because of a strong rationale, to either replace or have the animal lose a fixed amount or a certain amount of extracellular fluid. So I think for the matter of fluid replacement, we have covered the parts that were most relevant for today. And next time we are gonna cover more in detail the part related to fluid maintenance, which is the last component of fluid therapy, for a matter of three areas where fluid therapy is used therapeutically as resuscitation, replacement, and, as I said, ultimately maintenance. We'll cover that on the next lecture, and then we're gonna go ahead and cover specific circumstances where fluid challenges arise from the primary condition that we're treating. So I hope that you enjoyed, and as usual, keep watching our videos and we'll keep updating our channel. Thank you very much and have a wonderful day, night, whatever. Bye-bye.